Hello, everybody, and welcome to another World Medical Association Associate Member webinar. Thank you all for joining us. I'm Joe Heyman. I'm chair of the Associate Membership. Today, we'll be hearing about the challenges and opportunities in providing healthcare to migrant people, especially during a pandemic. Before we get started, let me say a few words about associate membership for those of you who are with us for the first time. The modern World Medical Association began at least partially in response to the horrible experiments done during World War II. We responded with our very important Declaration of Helsinki that ethically guides human experimentation and clinical trials worldwide. In addition to medical ethics, the WMA has policy on the socio-economic aspects of medicine in many living documents. It's an organization predominantly composed of national medical organizations and includes a secretariat in Ferney-Voltaire, France, near Geneva, a council and a general assembly, and many busy work groups. In addition, it has associate or individual members who support the organization. Associate members participate in an active online conversation group. We comment officially on all proposed policy. We participate in work groups, and we have special dinners and other activities when the WMA is meeting in person, and we get to enjoy both virtually and in person fascinating, wonderful, talented medical people from all over the world. Becoming an associate member is very simple and very inexpensive. Just go to the WMA website at wma.net and click on the box in the upper right that says join us. You won't regret it. Today's presentation will be in 3 parts. First, we will hear from Dr. Van der Laat giving his keynote presentation. Then we will hear comments and the WMA perspective from Dr. Kloiber. And finally, we'll have a question and answer session. You should all remain muted, but please use the question box on the right side of your screen to ask any questions which occur to you during the presentation. We'll try to satisfy all your questions. We're recording this webinar. That's just a reminder. You received a link to the resumes of both of our speakers with the announcement for the webinar, so please forgive my brief introductions. Now I'm very honored and grateful to introduce Dr. Carlos Van der Laat, the Migrants Health Assistant Program Coordinator of the International Organization of Migration. Dr. Van der Laat, it's all yours.
Thank you very much, Joe. Thank you very much for joining this webinar to all of you. This will be a presentation, but the idea is also to have a conversation with all of you in terms of what migrants, refugees, IDPs are basically encountering now in this new COVID era. So my name is Carlos Van der Laat. I'm a family physician and currently based in Geneva, HQ for IOM, working as Migrants Health Assistance Program Coordinator. I think that the objective of this presentation is to set base in terms of the challenging current context that migrants, refugees, and other displaced populations face in this COVID moment that we're living. We as health providers are now encountering many challenges. I know many difficult situations. Basically, the unprecedented threat from COVID-19, not just for our own health, I would say, but also impacting strongly on the health systems, our jobs, our families, spreading human suffering around the world, and affecting a lot the global economy. So it's very difficult situation that we are encountering right now. What we are now learning also from this experience is that we'll get through this crisis only if we act together in solidarity. So this virus is definitely a threat to all of humanity, regardless of nationality, ethnicity, faith. And this is why we are here. Basically, the world is as strong as the weakest health system. So us as health providers are part of that health system, and it's our job basically to improve those conditions and to make them more accessible for migrant populations and for the most vulnerable populations. So in order to continue responding as health providers, it's fundamental to highlight the specific conditions, the, the vulnerabilities, the needs of these populations, always recognizing that special actions need to be designed and implemented basically to guarantee inclusion. So I'm trying to move, but I don't know if I'm doing it right. There you go. Good. So basically, I would like to present a little bit in terms of IOM, because probably not all of us know about IOM. Basically, IOM is basically IOM is the UN migration agency. So basically, we are committed to the principle that orderly. Oops, I don't. I'm sorry, I'm struggling with this bottom here. Yes, basically, we are committed to the principle that humane and orderly migration will benefit migrants and societies. We do work specifically, it's an intergovernmental organization, and we do work specifically with partners, very linked, at least us at the Migration Health Division. We work very linked with all the health related agencies, with WHO, with UNAIDS, with UNHCR specifically. And the idea is basically to assist in meeting the operational challenges of migration management, always looking also at the positive side of migration, at their also working in terms of advancing the understanding of migration issues, always upholding the human dignity and well-being of migrants. This is the most important, basically the mandate that we have. Always look for people-centered approach and to look to benefit populations. With more than 436 offices and about 14,000 staff across the world, which include also specifically people working on health, risk communication, community engagement, etc. IOM is placed to provide support in international public health emergencies like the one we're living now from a mobility-centered lens. So IOM is always supporting member states on cross-border coordination and providing basically capacity building for surveillance efforts at entry points, etc. We are also working closely with community networks to enhance risk communication activities and help ensure that basically information on how that the information reaches those most vulnerable in terms of migration, in terms of also refugees, protection, etc. So this is like the main task that we have. This is a snapshot of the main activities that we are implementing as Migration Health Division. At least before COVID, now all our activities are basically also focusing a lot in COVID response, and we're adapting most of our approaches also to include COVID now as an important part of our activities. So this includes basically medical consultations in emergency settings. We can see there pre-departure migration health assessments for refugees and migrants. We do vaccination campaigns, antenatal consultations. We have also labs around the world, and we do active tuberculosis case diagnosis specifically for resettlement programs. We also have psychosocial support, etc. As you can see there, more or less 10% of IOM's staff is working directly with migration health issues. So now let's jump into the main reason for being here. So I will present some updates and some numbers also in terms of the current scenarios that migrants are encountering with the COVID crisis. We are seeing definitely a reduction in global, regional, and local mobility due to fear and also due to travel restrictions. We're seeing also lack of confidence in public health measures. We are seeing stricter health requirements for travel, which will probably also increase in the near future, in the future days. It will increase, and will increase also the need for health assessments, for testing, screening, education, health promotion, immunization, treatment, certifications, etc. So with more complex requirements, maybe not just at pre-departure, but also on transit and arrival, we'll probably see an increase in irregular migration and with it more health vulnerabilities. And that's why it's important to discuss this topic with you today. So now I think that we're learning many things with this COVID-19 situation. And now it's not necessarily only about leaving no one behind. It's basically that we are learning that if someone is left behind, basically no one will move forward. And this is why we need to really focus in these populations, not to leave them behind, because now with this type of infectious diseases, we're all in the same boat. So what's going on? Basically, meanwhile, most of the people were running to hide in their apartments, maybe, or maybe buying toilet paper. Some of them maybe complaining about the quarantine, adapting themselves to teleworking, or while we were also adapting our services to the new normal, responding to the increase of work in our units. For others, this has been much worse. Some people with already very vulnerable conditions before COVID are now struggling to survive, and this is the objective of this presentation, to get in touch with this. So with or without a virus, basically people continue to flee from war. War is still there, violence is still there, persecution is still there, and natural disasters also, and those conditions are still there. So we have big groups of people under very difficult situations and vulnerabilities, and now with the COVID situation, this is even worse. We're also see people basically struggling to maintain a living as migrants in the informal economy. And now with borders closed, with states closing all entries for people seeking protection and etc., the situations are being very complex. So we're seeing people in refugee camps, or people who are already asylum seekers, as an example, encountering now fear, hunger, stigma, discrimination, big uncertainty regarding their situation. And although all the countries are being affected, the top 15 countries most affected by COVID host more than 9 million refugees. So these are big numbers that we are seeing. In terms of labor migrants, in the 15 countries with the highest number of confirmed cases, 62 to 86% of those migrants are estimated to be in the working age, between 20 and 64. And are considered to be part of the critical sector. We also know that because of the lack of income security, incentive to work while sick is still there. So this also creates further spread to the virus. So many examples we can say. We have Mexican seasonal farm workers as an example in California or in other states in the United States. We have Indian construction workers in Saudi Arabia. We have a lot of domestic helpers across East Asia, as example, um, with huge numbers of people with lifestyles and life conditions totally linked to migration. We can recall big numbers like 280 million internal migrant workers in China, or 40 million internal migrants in India. All these groups, all these big groups of people are now or could be trapped in low-paid jobs in the informal economy, often without access to local healthcare systems or routine job protection. And basically, they are out of sight, out of any plan from most of the government policymakers. So you see these groups of people who are now suddenly without income. They can no longer afford to stay where they are. Even if they have savings for an air ticket, lockdowns and quarantines mean they are unable to fly home. Um, Now they become also, they could become irregular migrants, and they could become stranded populations. And the final outcome of all this is that there's more risk of infection and more risk to their health. We also see other vulnerable populations, among many other challenges that the pandemic exacerbates existing vulnerabilities. Migrants that were already vulnerable to possible abuse, those who have been displaced, those in detention, in prison, are now also being more affected, more vulnerable. Also gender. I think that gender is also an important, is considered a key determinant of an individual's migration experience, and the vulnerabilities resulting from gender can expect to hiding also in the aftermath of this crisis. So with 42% of all migrants being women, generally assuming roles in their host communities that are considered as essential, the exposure to the virus and to gender-based violence increases in an important way. So what we know is that female migrant workers are more affected by unemployment, and can experience double discrimination as migrants and as women in a host country. Um, we know also that there are increased barriers nowadays for accessing police justice or gender-based violence services. And finally, we know that when undocumented, there's also a lot of fear of retaliation, stigma, and detention. So those conditions are there. We need also to highlight right here. You can see it there in the slide that 75% of migrant women depend on informal economy, mostly in low and middle income countries. So this being much more than just a health crisis, it's also a socio-economic and a protection crisis. And within this health crisis, we're seeing also a big impact in terms of high morbidity and mortality. We have seen in the news that Latino communities are being were very affected in New York, as an example, etc. You can see that migrants are there in the news also in most of the days because of their high mortality, high morbidity. And this is basically due to many specific things, but I would say that maybe the most important condition to highlight is the fact that migrant populations are not assuming a passive role within this crisis. Interesting to see how society now, because of this virus, is starting to see the essential role played by migrants, who are front line responders who should also be recognized as heroes, showing up for work every day, to clean the streets, to keep up the food supply, to deliver food to our houses, to give care also to the sick as nurses, as physicians, and this needs to be recognized. And unfortunately, being there in the first line means also much bigger exposure to the virus. So this is why you can see higher mortality, higher morbidity for migrant populations. Also important to say that shortage of healthcare workers has been present at global level, and the demand for skilled health personnel is also exacerbated by the current pandemic. And migrants are essentially as seen as essential healthcare providers. Yes, we all know that's reality, but usually this is not recognized. This is not highlighted. So here in the slide you can see among the 15 countries most affected by COVID-19, at least 10 countries depend on foreign-born workers in healthcare. One example is Switzerland, right there, where 47% of doctors and 32% of nurses were foreign-born. So definitely, migration is also an important part of the health workforce, and we need also to recognize that, and in terms of vulnerability for our health workforce, and also in terms of recognition for their great job. Another condition also very important to focus again on migration as a determinant of health. So we know that tens of millions of vulnerable people on the move, living in cramped, unsanitary quarters where the virus spreads easily. Even the simplest measures, as physical distancing, hand washing, the use of masks, is just impossible under those conditions, under that context that they encounter. And so that's why our strategies as healthcare providers need to be also adapted and should always respond to the specific needs of the population. Based on stigma, very, very sad to say, but based on stigma, we have seen some national responses, closing gates, basically trying to separate the migrant populations from the national populations, from the host communities, because of fear to the virus. We have seen also refugee camps closed, not allowing people to go out from those spaces, but also not improving their conditions, not providing any support internally within those spaces. So these strategies are known to be totally inefficient because they finally increase the risk of infections for those who are inside these areas, but sooner or later also will affect also the rest of the community, and probably in higher proportions. So we know that many of the world's most vulnerable people live in informal settlements and slums in cities, and it is important to sit down, with governors and mayors. We need to work with urban health experts, government agencies, sanitation experts, urban planners, to stop the pandemic from spreading, while also guaranteeing also food supplies and access to healthcare. So this is very important also to work in those specific areas where we know that migrants are living. In terms of IOM, we reiterate the need for migrant inclusive approaches in the overall COVID-19 response. We need to highlight also the importance of addressing the particular needs and vulnerabilities of migrants, regardless of their legal status, and basically in the spirit of the universal health coverage. It is true that the fight against COVID simply cannot be won unless the response plans in all countries are including vulnerable populations. So now there's an increased need to bolster public health services in low income and humanitarian settings. The exacerbation of poor access to services, as well as constraints in terms of health financing, along with barriers to access hard to reach populations and to maintain supply chains. All of this threaten the continuity of care of essential health services also, that we need also to focus in strategies to work on these big issues. But not everything is so bad. Also, with this crisis, we are also seeing very good practices in terms of health coverage in some countries, namely Portugal, Colombia, Qatar, as an example. They during the current crisis, they have done positive decisions. They have taken positive decisions in terms of extending healthcare coverage to more categories of migrants, and this is also important. Also, we have seen some countries recognizing the importance of migrants, and even organizing flights for migrants to come, to their country to work. So these are, I think, that are positive things, and I feel that policymakers are now seeing the importance of inclusion with a different perspective. In terms of the socio-economic crisis, basically, we are aware that the current pandemic will have a broad-ranging long-term humanitarian and socio-economical impact. The economic and the political implications of this crisis are impossible at this stage to fully assess what is going on. You can see, I mean, these are basically the surveys done in a very fast way, but you can see that we're seeing challenging conditions for migrant workers. This was done, the one that you can see in the slide was done in April in Australia, showing that 50% have savings only for the next 2 weeks. Also saying 50%, half of the whole group have lost their jobs, and 74% said that they are not able to pay their rent. So yes, I mean, the situation is very, very, very difficult for these groups. Also, layoffs could trigger expiration of visas or also work permits, forcing workers into undocumented or irregular or in a irregular status. So in terms of the socioeconomic crisis, migrant workers are also, it's very important to be considered. Also, in terms of the socioeconomic fallout affecting migrant workers and refugees, especially those in low-wage informal economy, where they are usually excluded from social protection measures. So suddenly, without an income, they can no longer afford to stay where they are. They could now be able to meet, even they are not able now to meet their subsistence needs, and they have also this big stress in terms of not being able to provide to support their families back home, in terms of remittances. Remittances that are usually used for food in the communities of origin, for housing, to pay the education, to pay health services, and this is also affecting a lot many families and countries in general. So we see here a difficult situation also back home, with the decrease in remittances of $109 billion this year. That will affect approximately 800 million people around the world. So yes, remittances is a big issue, and also brings a lot of bad conditions and bad situations for communities of origin, including health also. Because also a big part, we know that a big part of those remittances is usually used for medical consultations and for treatments, etc. So in terms of the protection crisis, in terms of protection, we know that containment measures designed basically to limit the spread of the virus, which include also travel and mobility restrictions, have prevented people fleeing from persecution and war, from asylums, from seeking asylum. And this is a big issue in terms of protection. You know, people who are really um, in risk, their lives are in risk in the community of where they are, and basically they need protection, and now because of the situation they are not being able, no one is being able to provide any support. So we see a lot of stranded migrants and refugees who are more prone now to go through irregular channels, putting their fate in the hands of human smugglers. So more stranded populations because of lockdowns uh, uh, are increasing. These groups of stranded populations are increasing also, because now we're seeing also students, we're seeing also tourists being stranded, and all these conditions basically increase the risk of being victims of trafficking or child labor, etc. Also important to say here that the final outcome of this is higher exposure to the virus and increased risk of infection. Um, Here in the slide, you can see some conditions and some numbers. For example, you can see that the COVID-19 risk index, which reflects both the vulnerability and the response capacity, showing that the 10 countries most at risk of COVID-19 host a combined number of 17 million displaced people. So these are, as I have been saying, these are big numbers, big groups of population who are now stranded, who are now with increased risks because of the situation that the world is living. Finally, in terms of protection, we need to say that also health risks of COVID-19 are also affecting the humanitarian settings, such as war zones, displaced persons, camps, in which millions and millions of refugees and IDPs are living. All the lockdowns, all the closed borders severely impede also aid workers to provide life-saving assistance. And so this is making things more challenging. And we're also seeing a general funding uncertainty. So where you can see that based on the profound socio-economic impact of the pandemic, in all countries, globally. Also, that ends in the potential loss of trust in international cooperation and less donor support in the coming years. So this is also an important issue to see, the humanitarian setting, and how are we as health providers going also to participate in terms of providing more support to these places with increased risks. An important group that we need also to see and to check is the returnees. So we are still seeing a lot of deportations, even during the crisis, even during the sanitary crisis. Countries continue to deport families and people, creating big risks in terms of spreading of the disease. And also generating, the mental health risk, etc. And we're also seeing what is maybe not the best conditions for quarantine on arrival. So we have seen some governments with centers, to put people there for 14 days, 15 days, but without the sanitary conditions, without the basic areas for social distancing, etc. And so this is also very risky for those who are returning to their communities of origin, being in a voluntary basis or non-voluntary basis. So the panorama is not nice. There are some here. I just put some pictures of the current scenarios where, far from just health, you can see that we are really seeing in the day-to-day the reality of things, and we now know that this crisis is affecting a lot in terms of socioeconomic and protection areas. And very important also to say that also, and you can see it also in the news every day, how stigma and discrimination, fake news, bad informing is also affecting millions of people around the world. So you can see here is just an example of different publications that are there, where also linking migration, linking displaced populations with the virus, and then also showing that those that in some countries we really are not focusing on protecting these big populations that we have in there. So these are just to show some of the issues. And this last one, very important one, because it links to stigma, also saying that people are starting to see or continue to see migrants as carriers of disease, when we know, based on evidence, based on research, that this is not true. But now again, with the crisis, we're starting to see again a lot of xenophobia, a lot of stigma against migrants. And we have here an interesting statement. It says our greatest enemy right now is not the virus itself, but fear, rumor, and stigma. Well, yes, basically stigmatization is dangerous from a public health perspective. I would say is very dangerous for health, because stigma prompts social isolation of groups, and a fear of seeking medical attention, which in turn can undermine the effective inclusion of migrant populations in public health information efforts also. So this situation contributes to increased risk of virus spread, and to difficulties in terms of tracking and controlling any disease outbreak. Because if people have fear, they will hide, and if they hide, they are not easy to find for us in terms of public health. So this is also the reason why usually the UN system is against all those barriers, all those walls or closing borders, etc., because we know that people will continue to migrate, will continue with their plan, and basically the difference now is that they will do it hiding. They will do it through spaces that are not easy for us to reach, and that increases a lot in terms of health, all the risks in terms of health. So yes, basically I would say that to effectively fight the spread of the virus, individuals must have access to accurate health advice and adequate health care without fear of discrimination. This is also very important. You can see right now that some groups are basically excluded because of them being migrants. They are excluded from any aid. Also, we have been seeing a lot of reports of attacks against migrant populations, not just verbal but also physical attacks to migrant populations, etc. And this really needs to stop, because it can increase a lot the risk and the way we're going to manage this crisis. So now, going now into how IOM is approaching this crisis, and this is based on the experience we have had with Ebola. We came into what we call the Health Border and Mobility Management Framework. basically it defines our strategic role and expected outcomes in terms of prevention, detection, and response to communicable diseases in the context of human mobility. And very, very important to say that these efforts are central to safeguarding global health security and strengthening mobility sensitive health systems also that could deliver um, person-centered universal health coverage for all. Um, it also unifies border management with health security. That's also very important, and follows also all the mandates of the international health regulations. So also to say and to clarify that we follow all the guidelines and work very, very closely with WHO. So our input within the emergency, within the response, is more related to mobility issues, but we obviously we follow and work with them very closely in terms of their guidelines specifically. So this frameworks basically allows us to enhance the evidence based on mobility, dimensions for communicable diseases, allows us to build health systems and border health capacity, especially at points of entry, but also across the mobility continuum, all the route. Allows us also to engage and to empower mobile populations and host communities for population awareness and behavior change, promotes also the mobility sensitive policies and regulations through advocacy and technical support. And finally, allows us to promote multi-sectoral partnerships and coordination, which include also cross-border coordination. So this is more or less the theory, and this slide now is basically to tell you how we do it in the practice. So what we always want to highlight is the mobility continuum. So we need to really highlight that migration is basically very, very dynamic. It changes every day. It changes, and it's very, very dynamic. So we don't talk only about one spot, one space, but because we believe that all migration processes are linked and consider the whole migration cycle. So we always need to have to consider the community of origin, the community of transit, the community of destination, and also the community of return. So we need to see the whole picture. In order to do this, and specifically for infectious diseases, we talk about a lot about these spaces of vulnerability. Basically, what we're saying here is that human mobility connects communities and define common spaces of vulnerability. And these spaces are basically where there is increased risk of exposure to disease. Why do we do that? Well, because we want to focus in the space, not in the person, to avoid stigma. So that's the idea of this framework, to really focus in the conditions that are increasing the risks for the person, for the migrant. So we talk about spaces of vulnerability. And these are basically where they live, where they work, where they meet, where they pass. The idea is to define those hot spots, to look basically in all the communities where they go for lunch, or to go and search, directly in the transportation hubs, in the churches, specific spaces where we know that migrant populations will be. And this allows us to have a better targeting of resources, to resource allocation, and to prioritize communities so that we can work with them specifically. Also allows us to see the full picture and not just seeing migration, because this is a very classic error, that usually people see migration as borders, when that is not true. Most of the migrants are in the cities and just went through a border, but basically they are not in the border sites. So this is also important for us to see this, because this allows us to to strengthen and to reinforce primary health care along all the community, all the continuum, the mobility continuum. So based on this health border and mobility management framework, we have developed our response as UN agency for Ebola, for Zika, and now specifically for COVID-19. Our response is basically structured in 12 pillar activities, which are part of the global strategic preparedness and response plan. It is very, very interesting to see how this framework, which was initially thought from a migration health perspective, now is also being used by other divisions and departments within IOM, because they are also now adjusting to the new COVID moment and to the new COVID context. So this is also important to see. So across all of IOM's activities, priorities is usually given to mainstream protection concerns within the COVID-19 response, and to ensure basically that all our efforts are people-centered, are inclusive, and do no harm to the population we assist. So I'll briefly describe the pillars, but I would say that one common objective is basically to strengthen the health system, including health with its multi-dimensional definition. As an example, in terms of protection, actions include to enhance the capacities to ensure protection and access to services for migrants, travelers, displaced populations, including assistance to stranded migrants, people in need of specific care and protection, also including those left behind who have some sort of vulnerability or condition that needs some sort of support. So we also assess the impact of disrupting of the ongoing crisis on migrant and host communities in terms of their financial and socio-economic well-being and development, to develop policies and mechanisms that can improve their condition, and also to improve remittance service to migrants, to provide support, at least now that we are living the crisis. One important activity, and that's why it's also in the first ones that I will describe, is what we call tracking mobility impacts. So as movement across borders continue to be affected, IOM's capacity to provide data and analysis on population mobility dynamics remain crucial, for a targeted and evidence-based response. And this is not just for IOM, but other agencies are also looking for that information, because some of them, they really don't get much involved with mobility issues. So IOM, that's our mandate specifically. So that's why we do the tracking mobility impacts. Therefore, we use what is called the population mobility mapping, by which we basically identify mobility patterns, hotspots, and risk communities. Then we cross-analyze these public health assessments. We cross-analyze these mobility-related components with the health risk and vulnerabilities and the public health assessments and disease surveillance done at local level. And then we define priority vulnerable locations to focus our intervention. All this obviously is done by request most of the times, and in full coordination with the local authorities and partners, as I said, with WHO. Also, another very, very important one of our activities is the risk communication and community engagement. We work very, very closely with counterparts at global, regional, and national level to ensure that mobility is taken into account in public health messaging, and to ensure that information is communicated to migrant and mobile populations, which is usually not the way. So usually you can see ministries of health doing great job with their populations, but not necessarily focusing on those migrant populations who may not understand the language or even the way the message is is done. So this is very important. So as you can see, what we know is that legal status discrimination, language barriers may limit access to preventative materials, healthcare, and social services. We also know that public health announcements may not reach these populations, and they may not be included in any national strategies or interventions. And we also know that they could be also difficult to reach because of their mobility. So it's challenging to do RCCE with migrant populations, but also very important. So among other important reasons, these populations need, I would say, specific measures and strategies for community engagement. And I need to highlight this, that public health only works when everyone is included. So as health providers, we need to advocate for the inclusion and non-discriminatory access of refugees and migrants to public health services. We need to basically support translation and dissemination of public health information. We also need to disseminate information through the right channels, and these right channels are usually the NGOs or the same communities, the same community leaders that are there. That's the way to do it. Also important to include migrants in all the contingency prevention and response plans. We need also to advocate a lot in terms of of including migrant populations or most vulnerable populations in national stimulus packages. This is very important in terms of socioeconomic support, that sometimes they are excluded because of their nationality or migration status. And then the messages. The messages, basically, yes, we know that they need to be tailored. All our activities in terms of community engagement and risk communication need to be tailored, adjusting all the messages to the perception of the community, to the beliefs, to the practices, and etc. So it is very important to really adjust and send messages that are going to be effective with these populations. Another big important area of work that we have is what we call the points of entry. This is because we also have a division that is very strong and has a lot of a big network and works very closely with many governments, with many of the member states. That is called IVM, is specifically for border management issues, and they work a lot in terms of points of entry. That is also one of the main interests from the governments, from the member states, also to see how can they improve their systems at national airports, ports, and ground crossings. So what we do there for points of entry is we support active surveillance, including health screening referrals and data collection at POE. It is very important not just to focus in the migration authority, but also to work very closely with the health authority related to that point of entry. And very important to have SOPs, to facilitate detection, notification, isolation, management, and referral of all cases. So very important to have all those migration authorities well trained, so that when the patient arrives to the airport and has some sort of symptomatology, etc., that symptoms, etc., that could be that need some sort of support, basically they can refer directly to the health authorities within the airport or within the ground crossing. And this is very important to have it as mapped as possible, basically to have all those referral systems as the best established, and in the field, proven, etc., in terms of effectiveness. We also work a lot in terms of improving infrastructure, because sometimes these points of entry, they don't have isolation facilities, they don't have the best hygiene infrastructure, so we work a lot in terms of WASH, for water and sanitation issues, and to provide also the necessary equipment, the PPE, etc., for this in these spaces. Almost finishing. Also, we work a lot in terms of disease surveillance. Our focus is very focused in community-based surveillance. So what we try to do is we usually have community health volunteers or community health workers basically going to the places where the migrant populations are to also include that data within the disease surveillance system in the national level. And this is very important because usually our surveillance systems at national and local level usually consider only those persons who assist or who have access to the health service, and this is usually not the case, or most is not the case for many migrant populations. So it's important also for us to go and look for those populations to include them in terms of surveillance. So we work a lot in terms of community event-based surveillance and also linking this information with the mobility information that we are also collecting in what we call the participatory mapping framework. Also, as I said, infection prevention and control is also very important, and also in terms of developing protocols, specific protocol for these areas. Almost finishing. Also, I want to say a little bit in terms of case management and continuity of care. So we are also working to provide this continuity of essential health services. We're very worried about HIV, malaria, measles, tuberculosis, all these diseases that are still there, but that no one is now looking at them. Very worried about the medications that are not available anymore in some places, etc., and that we need to focus in that. So we're also working to directly with the ministries of health and with the partners to allow this case management and continuity of care. And finishing, I would say that it is the crisis also offers an opportunity to strengthen our societies by reimagining the future of human mobility to ensure that it is inclusive, safe, and respects human rights. So we, as physicians, as nurses, as public health leaders, as health providers, need to define our true role towards these populations and fight also against this toxic discourse, this stigma. I think it's time now to really push to reinforce the universal health coverage principles and based on evidence push also the global agenda. You see here the SDGs, you see here also the Global Compact on Migration. So I think there's good space in terms of policy also to push strongly in terms of reaching those universal health coverage goals, and our roles are very important to make this possible. And I will leave it there. Thank you very much for your patience, and happy to continue with questions and with the conversation.
Thanks very much. That was great. Just a reminder that you can put your questions in the question box while Dr. Kloiber is talking. And also, I just want to say that the likelihood is we will put the recording, we'll put a link to the recording on the WMA website in answer to one of those questions. Okay, so now it's my great privilege to introduce our wonderful Secretary General, Dr. Ottmar Kloiber. Dr. Kloiber.
Thank you, Joe. Thank you very much, and thank you, Dr. van der Laat. Carlos, I think you have given a very good overview of the migration issues and the broad portfolio the IOM has, with a strong view on health, on migration health. And as we have seen, it's not only the migrants' health, it's also the population health in general you are looking at. I was asked to give a little co-presentation with that. However, in view of the time which we have, what I would like to do is I would like to refrain myself on just a few comments from the point of the World Medical Association. And I have to start, of course, with a confession that during the last 4 months, where we have, well, actually it's already 6 months, where we have seen the COVID crisis rolling as a pandemic over this planet, that we have been more trapped to look into the questions of provision of healthcare in general, with some aspects that range into the migration issues, like, for instance, the discrimination we have seen with migrant communities in some countries, and even some migrant colleagues in some countries there, which of course is of very high concern to us. But I think we have not yet taken the approach in looking at the questions of migration and refugees with a special focus to the question of a pandemic. And we all know it's not only COVID-19, there may be the next pandemic around the corner. And what is very sure is there will be another one at one time. And I think we should be better prepared for what we do then. And that, of course, has to include also a look on our migrant populations. Now, I have not to declare any conflicts of interest, but what I would like to point to just very briefly is that we have policies that deal with the issues of migrant health. We have a resolution on refugees and migrants from 2016. The dates are always the ones where we have last updated the policies. We have another resolution on migration from 2018. All of them have some relation to the actual happenings during that time. And we also have a more methodological paper on the age assessment of unattended minors seeking asylum from 2019, a topic that is with us now for at least 3 decades. But we thought it was necessary to bring it to a policy level and to speak out of that. And then there is a whole bunch of other policies which have more or less a directly relationship to the questions of migrations. And I just would like to invite all of you to have a look at those policies, especially the ones on migration, which are very short and pretty easy to read and very clear. As I said, I wanted to go through this whole cycle of migration, but due to the time now, what I would like to do is I would like to jump to my conclusions and rather give some comments so that the other participants have also an opportunity to ask questions and we can answer to some of them. I think I completely agree, or we completely agree with you. When it comes to the right to health, there is no classification as citizens, inhabitants, or documented or undocumented migrants or whatsoever. The right to health is a human right. For us, that means access to quality health care and not anything less than that. And the tool to achieve that that we find is most appropriate, and I think we agree completely with you, Carlos, is universal health coverage, something that we have to strive for and that countries have to build. When there is universal health coverage, or at least something that comes close to it, I think there is no system in the world that really can claim that it is completely universal, but we have a number of healthcare systems which are already pretty good. And wherever it is possible, we found that it is advisable to grant migrants the same access to healthcare as all other people. Why? Because this will clearly take you off the hook, the politicians and also the doctors, from the allegation that you are providing not enough because you are unfairly discriminating migrants. And on the other hand, it takes you off the hook from the allegation that you would give an undue preference to migrants. Yes, there are specific needs that have to be taken care, like specific needs other people have. But again, if you have a system that works, then the best thing is just to put those people in the system. And by the way, there has been also economic analysis of that. It's a very economical way to handle this problem. So it is certainly very good to give migrants the same access to healthcare than any other people. Yes, I know there are still a lot of healthcare systems in the world, and unfortunately many in those countries where migrants are being stranded, which don't have proper healthcare systems. That is a problem, and that needs attention by the international community. We're grateful to IOM, but also grateful to other UN groups which give assistance there, like UNESCO, or private organizations that help. We, as the World Medical Association, cannot expect that this problem will go away. We have to look into this question again when we revise our work on pandemic preparedness and disaster preparedness. I think there is something which we have to focus and concentrate a little bit more on, the migrant situation and migrant health situation. But we also have to advocate more for very clear national and international regulations, as Carlos had outlined them, that they are being applied indeed, agreed on and applied in order to protect human rights and humanitarian values. With that, I stop at this moment, Joe, and hand back to you in order that we can have a discussion and maybe be able to comment and answer some questions. Thank you.
Great. One of the questions from Dr. Cecil Wilson is, can you point out places where the health border mobility management is working and some that are not working? And maybe an explanation as to why. We can't hear you, Carlos.
Yeah, sorry, I muted. Should I respond right now, or we just?
Yes, please.
Yes, I mean, it's very, very difficult because it is applied. I mean, this is an IOM's framework. So this is basically our strategy to work with the member states, with the counterparts, with the partners regarding the border health issues. So I would say it has been used in many countries, specifically during the Ebola situation. We applied the whole framework. They're providing a lot of training, which is also very, very important to define, to train not just the health provider, but also the migration authority, and to have the SOPs well validated and functioning in terms of, you know, that people could be referred to a health authority immediately, but also to improve the capacities of the migration officer to detect and refer, as an example. So yes, I mean, it's really, really difficult. I would say that it was our framework. It was proven or used a lot for the Ebola response, and now basically it's changing a lot. Now we have this new challenge of the COVID, where we're not talking about 3, 5, 6 countries or a region, but we're talking about a global response, a global situation. So nowadays, basically, this framework is the one that we are using to basically provide support to the counterparts, the member states, and this is being applied. I mean, finally, the ones who apply the suggestions, the recommendations are the governments. And yes, I mean, for me, it's really difficult to say specifically which countries, because it's an internal framework. But I think that it is really, really helpful, basically, to link the migration sector with the health sector, which usually work totally separate. You go to even at local level, you go to a border, and you can see that the health authorities have never met the migration authorities in place, and things like this. That in the same country, now even worse and more difficult also to find you know, cross-border communication, cross-border information sharing, cross-border joint actions. This is very, very, very limited, and that is exactly what the framework pretends to establish. You know, these different these objectives, basically to improve conditions when dealing with this type of situations, not just for the emergency, but also in terms of preparedness also.
Okay. We had a couple of questions. Maybe I'll just summarize them. Well, first of all, we have somebody who works at a camp in Bangladesh for migrants, and he just wants to make certain that we call attention to the Rohingya crisis. And I just want to make sure, I noticed that it was in your presentation, but he wants to make sure that people are living there in a situation where there are 90,000 people per kilometer. And he thinks it's a terrible situation. So if you wanted to comment on that at all, in particular, that would be fine. If not, we'll just go on to the
Yes,
next.
no, no. What I can say is that that is a perfect example of what I presented in terms of the already terrible conditions that some populations had before COVID. You know, living in camps that are basically totally overstretched. You know, with very difficult conditions, with no access to water, with no basically impossible to keep social distancing, as an example, in those places. So this is a perfect example, you know, of already existing pre-existing bad very vulnerable conditions like what it's happening in these camps, and now you know, giving a higher high risks and higher vulnerabilities related to the COVID response. So yes, I mean the Rohingya, we do have we do have clinics and activities as IOM within Cox's Bazar, along with other colleagues and other agencies that also have a lot of activities in there. But yes, that is exactly the example. And now also an example of how challenging it is, because basically we are constantly sending human resource to these places, changing the human resource, sending supplies, etc. And now with the lockdowns, it's just impossible to move forward. So this is also our big concern now in terms of how to continue with the essential services within this complex situation of lockdowns and borders closed, and also fear from the same communities, etc.
What level of engagement and working relationships, well, I would say, does the IOM have, and should the IOM have, with national medical associations, and what can national medical associations do to help with this problem with migrants' health?
That is for Altmar, or?
That's for both of you.
Okay, good.
In either case, whenever I ask the question, either one of you can answer.
Yeah, I'm happy to start if that is okay.
Sure.
Yes, we have as national medical associations a number of contacts to the work of IOM, but also to the work with migrants in the countries there. The IOM as an international organization is rather a partner for WMA, or we are a partner to IOM in this work. But on the national level, there is a lot to do for national medical associations. Some of the points Carlos has already mentioned. We have problems like, for instance, discrimination and exclusion from the healthcare systems, which I think we have to overcome, and which something is what medical associations have to work on and advocate for very actively. In those countries where this is not a problem, and there are fortunately some countries in this world where the inclusion of migrants and refugees into a health system has been taken place, there are still very particular problems, like, for instance, language barriers, where we have to find solutions in order to overcome those. Using relatives is not always a good idea to do that. Thinking about the psychological problems that some of the refugees and migrants have coming from violence they have experienced during the time. So it needs really indeed a deeper look in what professional services are necessary there in order to do that. Fighting stigma is another one to do that. Overall, I would say it is our work for universal health coverage that we have to bring forward, which cannot leave anybody behind, to bring it to a bottom line formula. If I may, in this context, also answer the question of Dr. Sundaramurthy, which is the priority? Is it physical and social or psychological in that? The reality is, at least that is my experience, which I had, and that is an experience from Germany, so it may be different in other countries. There is clearly a very strong focus on physical health and social support. That is something that runs more or less automatical in a good system, where you have entry examiners and put them into a healthcare system, provide them with assistance and welfare. But what we have found out is that for many of those migrants and refugees, the long-lasting problems and sometimes the more severe problems are really psychological and psychiatric problems, because they usually come, not usually, they sometimes come with a trauma situation. And this post-distress situation, which they have to live with and work with, is something that has not been addressed properly enough. And we have been advocating for putting a stronger focus on that. That again is tricky, because if you say every migrant goes through a psychiatric screening, you put on another stigma on these people right now. So you have to be very careful in applying this. But it came very much to our attention that this is something we have to advocate for and have to see that we can provide this as well. But again, bottom line is universal health coverage. That is the way to go. That solves a lot of those problems.
Yes,
yes, go ahead, Carlos.
No, I fully agree, and I think that the level of engagement is good, and I think it should be improved also. I think maybe what I can see from my side is that we are working closely, but specifically more for the policy level, maybe more focusing more in the policy level, a space where we need a lot of support, and we need to do a lot of join forces also in terms of advocating for the inclusion of migrant populations within the policy level. That I think that is very important and very challenging also, because of all the things that I said during the presentation, you know, all the other forces, negative forces against migration or against migrants. So I think that's one space where we need and where we are working very closely. But I think also that as you said, as I said during the presentation, there are a lot of our health workforce is also based of migrants. We do have a lot of migrants who are physicians or who are basically health providers, and that also I think that so probably a lot of your members are also living this migration experience, and so I think it could be also really good to touch base also regarding that issue, and to see how they as health workforce are seeing, are engaging with the migration challenges. That could also be very interesting. We also have a lot of, in the presentation, it's called the Migration Health Research Portal. So this is a portal where we are linked with a lot of very high level researchers around the world who are specifically doing research on migration and health. So I think this also could be shared with your members so that they have access to the most recent research being done for migration health issues. And then also in terms of capacity development, I think that we can in both sides learn a lot from our experiences. I know that there are many of your members also working directly with migrant populations, as the colleague who did the question right now about Bangladesh. So I think that we can also enrich a lot our experiences also through sharing information, sharing best practices, and even capacity development. You know, basically also having groups who are interested in specific topics that also we as IOM can provide. You know, that information is I think those are the areas that we can really strengthen.
Is COVID making it so that we're ignoring other health problems in certain areas? And are there certain parts of the world where, because of COVID being so important in Europe and North America, other problems are being ignored?
Yes, for sure. I mean, for sure. And this is the big concern also that, as I said, basically, the tuberculosis is still there, malaria is still there, HIV is still there, violence or gender-based violence is still there. I mean, many different areas, many different vulnerabilities are there, and we're not really being able. I think that our health services are really overstretched now, focusing only on COVID and not necessarily being able to guarantee that continuity of essential services, and this is very challenging, not just in terms of the service. We need to also say that we are seeing our health workforce also very affected. So big groups, a lot of colleagues who are sick because of COVID, who are not being able, to provide their services. So this is an important thing, but also in terms of the supply chain, a lot of difficulties to bring medications in a country, and equipment, etc. So this is really affecting. We have a lot of communication, as an example, with the Global Fund and with with Gavi and with these big institutions, who are also very concerned in terms of what's going on with the non-COVID side of reality. See, I don't know. I really feel that we need also to focus a lot more in guaranteeing that continuity of services. How to do it is the big challenge, the big question. But definitely we need to also move forward and adapt our strategies to be able to provide both, the treatments for the normal or for the day-to-day pathologies, but also adapting them to COVID. And that is more or less what we're trying to do in some countries. We have a big project on HIV, malaria, and tuberculosis in the Middle East countries, as an example, and it has been very challenging. But what we're doing is that basically the same colleagues who were working specifically to provide services on HIV now are doing both. They provide the HIV and also health promotion and risk communication activities with regarding COVID. Yeah.
And I know you just sort of touched on this, Carlos, but somebody is asking about international medical graduates from one country who are working in another country, and specifically, how does the IOM support them, and what does the World Medical Association do to support them? So maybe each of you could just briefly comment on that.
Should I start, Carlos?
Yes, I always prefer it like that.
Well, I think for most of it, let's face it, for most of it, the international medical graduates or the migration in the health professional field is certainly the better part of migration that we see. So most of those people are not that much in distress, as we see this for migrants which flee for other reasons like war, famine, poverty, ethnic conflicts, and so on. Nevertheless, there are specific problems that these groups have, and we advocate very strongly for finding solutions on, for instance, multilateral recognition of diplomas, so that they get an equal treatment in their countries as in their own countries. We demand actually equal treatment, which is very important because sometimes even physicians are being imported as cheap labor from other countries and are being put in secondary position with less payment, or even sometimes without a real payment. So that is something where we have been very active in the past for asking for the same rights and entitlements as anybody else, but also for asking for the same qualifications. So we don't want to undercut any requirements for qualification of, for instance, physicians moving from one country to another. Language competency is, for instance, one, but also subjective competencies that have to be demonstrated. So that is something we are advocating for. Some of our regional groups are going far deeper, like the European ones, which has a very elaborate system of bilateral or multilateral recognition, which is something they have been working on now for, well, close 5 decades. Yeah, thank you.
Anything to add, Carlos?
No, but it's more or less the same. We're also working very closely with our colleagues in ILO and WHO for the health workforce specifically. And not, to be honest, we don't have a lot of link with the international medical students specifically, but yes, with the health, with the health workforce. And yes, basically it's about certification. We have big issues also with asylum seekers. We have many countries where asylum seekers are not recognized. So we have great surgeons, you know, who are asylum seekers in a different country, and basically they're not allowed to work. They are not allowed. They're not recognized as for their medical skills, and this is really very bad for all, you know, for also for the person, but mainly for the community for the host community, who is also missing this great opportunity of having a great surgeon, you know, working in that area, in specific areas. So it's a lot being done jointly with I would say with other agencies, with a lot of push from WHO, from the UN side. But yes, also very important in terms of the certifications and yeah, to allow really a fair business, also not just for the students, also for the country of the sending country also, because also we need to verify that, also to check if there is enough health workforce in the sending country, also to avoid, you know, leaving them without the human resource. And this is all basically in conversations and in coordination with a big network.
Okay, well, we've pretty much reached the end of our time. We have one more question, which we'll just very briefly answer, and that is there a different approach to migrants in developed countries versus developing countries? Carlos, why don't you just quickly give
Yes,
a quick
answer. I would need to say that there is a different approach basically in any country. I mean, every country has a different approach to migrants and to migration. Usually, the developed countries, they usually find migration as a great thing. I mean, basically, some of the developed countries depend on migrants in a big way. You know, some of them have populations that are very old now, that they don't have manpower, and they need migration in order to keep, you know, the level of manpower to keep the normal economy in their countries. So there are like two discourses. One that is that it is the positive side of migration, which is usually part is there. And then this negative that is more, I don't know, basically used as a political tool, you know, to gain votes, but not necessarily a real one. So I would say that in both sides of the question, in the developed and in the underdevelopment countries, migration is seen as a great thing. In the sending countries, the remittances are very important. We have countries where basically the country, the major income for the country is based on remittances. So also this is also very important. You know, countries like Guatemala, like El Salvador, etc. They really depend on remittances. Basically, that's the final thing. So yeah, I would say that the approach to both in both sides is different, but also usually very positive in the majority of times, you know.
Okay, Otmar, do you have anything to add, or should I wind it up?
Thank you very much, Joe. I would just express my appreciation for this idea to have this webinar here, and I think it's very timely and very helpful for us. Thank you.
Thank you
Okay,
very
I
much.
just wanted to add for those who are guests that if you join the associate membership, you're capable of proposing policy, and that we have a very active Google group, and that would be a way to continue this discussion. I want to thank both Carlos and Otmar for such a wonderful presentation, and thank you all for joining us very, very much. And we'll say goodbye now.
Thank you so much. Bye-bye.
Thank you.